Hi, I'm Taylor Reimer, and this is my project on peptic ulcer disease infected by Helicobacter pylori. The key concept is altered nutrition. Peptic ulcer disease occurs when the protective gastrointestinal mucosa barrier of the GI tract is broken down, causing acute or chronic ulcer formation. This can occur anywhere along the GI tract, including the esophagus, stomach, and small intestine. The key attribute to peptic ulcer disease is altered nutrition. Some consequences of untreated peptic ulcer disease include nutritional deficiencies, where peptic ulcers will decrease the surface area of the GI tract, altering the absorption of key nutrients. Also, iron deficiency anemia can happen from peptic ulcers causing the GI bleeds, which can deplete the body's iron stores when trying to replace the lost blood. This is especially dangerous if the bleed goes unnoticed for long periods of time. To the right, you see a bubble with the word nutrition in it. I made a bubble diagram adapted from the Giddens textbook to show the related course concepts to altered nutrition that can happen with peptic ulcer disease. Some of these concepts include spirituality, culture, glucose regulation, immunity, tissue integrity, and clotting. Now, normally all layers of the GI tract are intact without erosion, but with peptic ulcer disease, we have acute ulcers and chronic ulcers. An acute ulcer is characterized by inflammation and minor erosion, as seen here, and a chronic ulcer is characterized by significant inflammation as the acid has eroded into the muscle. These are much more common than acute ulcers. Some causes of peptic ulcer disease include ischemia, alcohol use, chronic NSAIDs, acids, and bile salts use, and the one we are focusing on today is an infection by H. pylori bacterium. Patients with peptic ulcer disease are at significant risk of perforation, leading to gastric contents spilling into the peritoneal cavity. As previously mentioned, people with peptic ulcer disease face the risk of nutritional deficiencies and iron deficiency anemia. Pain can be present with peptic ulcer disease. Many pain medications are hard on the GI mucosa, so people with peptic ulcer disease are not able to take medications such as NSAIDs. Here is a flowchart I adapted from Lewis MedSurg to show the cause of peptic ulcers by Helicobacter pylori. First, H. pylori enters the GI tract and generates ammonia, allowing the bacteria to penetrate through the acidity of the stomach and into the underlying tissues. This creates inflammation in the mucosa and makes the tissue vulnerable to break down from the entrance of stomach acid. An ulcer is created when the cell renewal cannot keep up with the cell breakdown rate. The transmission of this infection is fecal-oral or oral-oral. The following are manifestations of peptic ulcer disease. The patient could have all, one, or none of these manifestations. The patient could vomit fresh blood or coffee ground-like emesis from digested blood. Pain due to gastric ulcers occurs 1 to 2 hours after a meal. The pain is in the upper region of the abdomen. Patients describe this pain as burning or gaseous pain. Pain for a duodenal ulcer is located below the xiphoid process in the mid-epigastric region. Patients describe the pain as burning or cramp-like. Ulcers on the posterior aspect of the duodenum can be manifested as back pain 2 to 4 hours after a meal. Melena or black stool could be present due to bleeding from the ulcer in the upper GI tract. It's also fairly common for people with peptic ulcers to have no pain due to the low number of sensory pain receptors along the GI tract. The following is a nursing assessment for a person presenting with symptoms related to peptic ulcer disease. First, the interview. You'd want to ask ample questions for the background history, age, allergies, medications, past medical history and any recent surgeries, your lifestyle such as do you smoke, use drugs or alcohol and drink caffeine, and the entrance complaint, what is your concern. You'd want to take the patient's vital signs and do an OPQ or STU pain assessment. Pain onset, palliation, or precipitation, what brings it on, what relieves the pain. The quality of the pain, is it burning, cramping, stabbing, anything like that. The region of the pain, the severity on a scale of 1 to 10, the time, so how long it lasts, when it comes on, and the understanding of the pain. Then you would ask the patient if they have any nausea or vomiting, and if so, what comes up when you vomit. Is it red, coffee ground-like? Do you vomit food you just ate? When was your last bowel movement? Is it soft or hard? What color is it? Because black stool could indicate occult bleeding. Do you have flatulence? And does your family have a history of peptic ulcer disease, esophageal varices, stomach or colon cancer, or gastritis? Some labs you can anticipate being ordered for the possible peptic ulcer disease is a culture and sensitivity of the blood as well as a stool sample to test for the H. pylori. You would want hematocrit and hemoglobin, bun and creatinine for kidney function, a fecal occult blood test, PT, PTT, INR, and APTT. For diagnostics, you can expect an X-ray to be ordered to rule out a possible bowel obstruction. For the physical examination, you would want to conduct a head-to-toe as well as a full abdominal assessment. Observe the shape of the abdomen, auscultate for bowel sounds, and palpate for masses and pain. A broad-spectrum antibiotic to treat this infection is amoxicillin from the class penicillin. The indication is to treat peptic ulcer disease from Helicobacter pylori. This drug weakens the cell wall of the bacterium and allows water to enter, killing the bacterium. Human cells do not have cell walls, so this does not affect the body's cells. Pharmacokinetics. The absorption, amoxicillin is taken PO, absorbed through the GI tract to be metabolized by the liver. Distribution. It diffuses readily into most body tissues and fluids. Penicillins can cross the placenta and into the breast milk. Metabolism. Amoxicillin is metabolized by the liver. The onset of this drug is 30 minutes. Excretion. This drug is eliminated from the body by the kidneys into the urine. The therapeutic effects. The desired effect of this drug is to kill the H. pylori that was causing the ulcers. To assess for this, assess the patient's occult blood or melena resolving, no presence of hematemesis, no pain 1 to 2 hours after eating for gastric ulcers, and 2 to 4 hours for duodenal ulcers. Side effects. An allergy observed for fever, urticaria, pruritus, and of course anaphylaxis. GI upset, diarrhea, abdominal cramping, nausea, and vomiting could be present. Antibiotics could cause a superinfection from disruption of the GI flora. And electrolyte imbalance. Monitor for hyperkalemia and hypernatremia before and during the therapy. Pertinent nursing implications for this drug. Observe for the first 30 minutes because allergies occur more in penicillins than any other antibiotic class. Monitor the vital signs before, during, and after, especially the temperature. Cardiac symptoms should be monitored because of the possible side effect of hyperkalemia and hypernatremia. Monitor for GI upset and signs of superinfection as previously stated. Teach the patient the importance of taking the medication for the prescribed duration, usually 10 days. Even if symptoms go away, the antibiotic is still working to eliminate the last of the infection. Antibiotics may decrease the effectiveness of oral contraceptives and monitor renal function and hepatic function.